morning, everyone. This is Tammy with Churchill Coalition. I was just wondering, was there an agenda sent out?
Yes, I sent out an email with a link to the agenda, last meeting's minutes, and one of the presentations on Thursday. And I was actually just pulling that up here in my email in case it wasn't seen. Let's see here.
So Stacy, this is Tracy, and it might be beneficial since this is kind of the first time that you've done this process where you've actually did send it out in an email, and it was on Friday, April 7th, and it went out about 2:54 in the afternoon. And just so folks know, then the second sentence that says, please follow this link, and it actually has a link that takes you to the Division of Public and Behavioral Health website. So Stacy, maybe you can kind of show folks, for those who are on and have their cameras, where that is. You could kind of open that link and then show them, and then they can see the agenda right up on top.
Okay.
That might be helpful.
Sure. And I did, as you were speaking, I just resent that just to see if that could help too. And if you'll bear with me here while I get that site open, I'm going to stop sharing so we don't have anything that shouldn't be shared.
I did get that on the 7th.
You did? Oh, good.
I just wanted you to know I did get that. So I'm going to that link now. I just didn't print it out. I was looking for attachments this morning to print stuff out.
Okay, sure. Yeah, I was, and it's always the best intentions. I thought, oh, that'd be a really nice package to send it to everyone. But yeah, it's just getting used to some changes, so no problem at all. But to Tracy's point, let me go ahead and pull up what that site looks like, and where it takes you. So let me just get this shared. Okay. So what I'm trying to do is show you the website here. Here we go. So that link would take you to this page, and then of course you can see each meeting is, the most recent meeting will be on top, and those links will take you right in to the agenda. And I'm happy to also, of course, email it out. I was just trying to be as efficient as it appeared to me to be. So that's that for now. Okay, let me go ahead and shut this down. Okay.
Stacy, I count 8 or not. Oh, yeah, I count 8 or 9 SAPTA advisory board members. Is that what you count? And what do we need for quorum?
Let's see. So for quorum, we need for quorum we would need 8. Yeah, that's right. So let me take a look here. We've got 42. Jamie, would it be easier for me to say after we do the roll call?
Yeah, why don't we go ahead and open the meeting at 12:07. Sorry, 9:07. I'm on East Coast time. Apologies. 9:07 a.m. And Stacy, if you want to do the roll call, we'll hopefully be able to get started. Thank you.
Okay. All right. Here we go. So we've got Jolene from Quest Counseling.
Present. Good morning.
Good morning. And of course, we know we have Jamie from Pact Coalition. David Robeck from Bridge.
Morning.
Thank you. Lana Robards from New Frontier. I think I saw you, Lana.
I'm here.
Yeah, she's
Thank
waving.
you. Okay,
If they're on
thank you.
camera, they're just waving.
Okay, and I'm looking over here, so that's fine. Okay, Michelle Berry from CASAT.
Present.
Thank you, Michelle. And then, so Community Counseling Center of Southern Nevada, Kay Villardo or Patrick? No. All right. Tammy Sheminsky from Churchill Community Coalition.
I'm here.
Thank you. From Join Together Northern Nevada, I have either Ann Elizabeth or Jennifer.
You can take Jennifer off the list, but I
Okay.
don't believe Anne Elizabeth is in the room right now.
Okay. Thank you. From Bristlecone, Lena or Peter.
This is Peter. Thank you.
Thanks, Peter. From Step 2, I have Mary Hutchinson.
This is Mary. I'm here.
Thanks, Mary. From West Care, Leo.
Good morning, everyone. I'm here.
Thank you. Wendy Nelson from Frontier Community Coalition.
I'm here.
Thanks, Wendy. I think I saw Esther Quillisi from Vitality.
Here.
Okay. Dan Tillman or Gina Flores O'Toole from Ridge House. Okay. Jasmine Cooper from Help of Southern Nevada.
I'm here.
Thank you, Jasmine. And then we heard from Jackie from Carson City Counseling Center or Community Center. Yeah.
Yep, Carson City
Oh.
Community Counseling Center.
Thank you. Community counseling. Got it. All right. So we're missing 3 people. So that looks like a quorum to me.
Wonderful. And Stacy, this is Jamie again. I
Mhm.
thought we were going to keep the chat on so SAPTA staff and guests could put their name and their agency in, so that will make your doing minutes much easier. But I see that it's been turned off. Is there a way to turn it on just so folks
Well,
can log in?
You know, I had actually I had enabled it, so I'm surprised that it's turned off. Let me take another look. It should be. Oh, it did. It went back to being disabled. Okay, I don't know why it did that, but the what we had decided to do is leave it on and until this was actually new instruction that just came to me this morning. We were going to shut it off after roll call, and then there is an attendance report that is generated at the end of the meeting that we were going to use to record everyone's attendance. But thank you
Okay.
for mentioning that, because yeah, I had to say I had enabled it and it somehow went off. So.
Wonderful. So yes, please, if you are not a member, please go ahead and put your name and your agency in the chat. Please do not use the chat to communicate anything other than your name or agency. Otherwise, the Deputy Attorney General gets real mad at us. So please don't do that. But please do put your name and agency in the meeting or in the notes. And we will go ahead and get started. We have done roll call, so let me read the new housekeeping items we have. Please note that this is a public meeting and it is subject to open meeting law, and it is being recorded. Only members of the SAPTA Advisory Board and or staff of the Advisory Board are able to speak. Agenda and supportive materials have been posted on the SAPTA and Nevada Public Notice websites. When speaking, please remember to state your name and your agency. The chat feature will be disabled after we all sign in, and Stacy Whitkey will handle all content sharing. So yes, this meeting has been properly noticed and agendized, and we are good to go to agenda item number 2, which is public comment. This will be the first of 2 public comment sections, and anyone is able to speak whether you are a member or not, and it should be limited to 2 minutes. So I will open the floor.
Good morning, Jamie Ross. Am I allowed to speak? This is Antonia.
Absolutely. Welcome, Antonia.
Thank
Please
you.
state your name for the record. Not that we don't all know, not that everyone in prevention doesn't know you, but I don't know that all the treatment people know you.
No worries. Hi, everybody. My name is Antonia Caporelli-Twait. I'm a health program specialist for the Department of Public Behavioral Health. I currently oversee the Strategic Prevention Framework Partnership for Success grant. This is the 5th year and the closeout of the grant, and the state of Nevada will be applying for the notice of funding opportunity that was provided from SAMHSA on Monday, April 3rd, 2023. For the states to apply. I would also like to announce that there's a notice of funding opportunity for the Strategic Prevention Framework Partnership for Success for communities. Eligibility is for communities, local governments, universities, colleges, tribes, and tribal organizations to apply. The notice of funding opportunity number is SP-23-004, and applications are due by Monday, June 5th, 2023. And to view the details, if you could please go to samhsa.gov, and it's under the fiscal year 2023 grant announcements to view all the details. Thank you.
Thank you so much, Antonia. And if you are an agency that is planning on applying for the PFS community, please reach out to Antonia. She can get you connected. We believe that there will be multiple community grant applications being supported or being written. So please reach out to Antonia if you are planning on applying for that, so that she can be aware and we can all write appropriate letters of support for one another. I don't see any other hands up outside of Antonia.
Jamie, I'd like to ask for a future meeting. I'd like a list of the actual board members for SAPTA. I'm a little confused now as who's a board member, who's not a board member. We used to have to represent something in the treatment field. I don't know if that's the case anymore. So do you have the list?
I have an old list. And yes, Esther, it used to be that the agency was the member, not the person. So I'm representing PACT Coalition, Leo's representing WestCare. So yes, that is my understanding. That has not changed in the bylaws, unless someone smarter than me did. Okay, David was the former chair and he's shaking his head. So yeah, those are still the bylaws. And Stacy, would you be able to put that on on the minutes or an agenda for the next meeting?
Yes, I just wrote that note down. Yeah, thank you.
Okay. Actually, technically, I don't think we're allowed to take action on this because it's public comment, but there is a second section where we're talking about this. And so, Esther, we're going to table this until we get to that section, and then you can ask your question formally. So again, that the Deputy Attorney General doesn't get mad at us, because Cody Finney jumped on, and I feel like that might be what she was gently scolding us for.
Oh no, I wasn't going to scold you. I was going to say we could distribute the bylaws, have a future agenda item to go through them if you don't already. I must admit I did not look at this agenda today. And also that anyone the chair recognizes is allowed to speak. So just a couple housekeeping issues. Hang in there, you guys. We're getting it.
Thank you, Cody. And Stacy, I don't know if you saw, but Ann Elizabeth from JTNN was able to join us. So if you can mark her present. And also, yes. I believe Gina O'Toole is also present now.
Thank you.
Wonderful. Any other public comment? Okay, we will close agenda item number 2, open agenda item number 3, which is approval of the minutes. Hopefully everyone had a chance to review the minutes. And are there any notes or changes that need to be made to the minutes?
No, I so moved, Madam Chairman, to approve the minutes as published.
Wonderful. I have a first from Esther.
A second from David.
And a second from David. Any discussion? Wonderful. All in favor, please say aye or raise your hand.
Aye.
Aye.
Aye. Any opposed? And abstentions? Wonderful, that passes unanimously. We will close agenda item number 3 and open agenda item number 4, providing a co-chair report, and that is Jolene and I. And I have prepared really brief statement, and I just wanted to bring this to the attention. I think I saw many of you in the open meeting that DPBH put out about agencies that had been previously funded, and funding issues and reimbursement issues, and wanted to publicly thank the staff from the state who were there for a wonderful discussion. I think it was a really helpful meeting, and wanted to thank them for putting all of this together. Some notes for the members and other folks within who are listening in. If you are having issues with DPBH, this is my incredibly strong recommendation that you follow up before the situation becomes untenable. And if you are unable to get the information you need from someone within SAPTA, feel free to reach out to Cody. Cody has given her contact information. She is very excitedly waving at all of us to make sure that we know we can reach out directly to her if we are not able to resolve our issues. If there was an issue that you brought up at that meeting and it has not yet been resolved, please reach out to Shannon and or Cody and or Lisa to follow up directly to ensure that that is being resolved. And I will say that some of the partners that I've spoken to, and I haven't spoken to nearly everyone who spoke publicly at that meeting, but that the issues have not been resolved, but they are being worked on. So if you have not heard from anyone within the state, please reach out. And that is my public co-chair's report. Jolene, I don't know if you had anything to add.
I do. Thank you, Madam Chair. I appreciate it. Good morning to everyone. I just wanted to follow up. As you remember, or may not remember, in February, I spoke about some challenges that we were having. And I just wanted to note that I think the communication between SAPTA and our staff, at least, and I've talked to a couple other providers, it has improved. We've received more timely email responses, and we've just had more conversation and contact, a couple extra meetings, which has been very beneficial for us. I feel a little bit more supported. And we also were paid for the NOFO award that we had been waiting for 7.5 months. We were paid for that in February. So those are all improvements, and I really appreciate, yes, that I feel like we were heard and that people moved into action, and I look forward to even more communication and just working together. So thank you for everybody who has helped to make that happen. And I was really bummed to have missed the town hall. I was out of town, but we had a staff member that was present, and I heard it was really done well. So thank you.
Jamie, I think you're muted.
Thank you, Stacy. Any comments or questions from board members? Or SAPTA staff who are being spoken about?
So this is David at Bridge in Las Vegas. So first of all, I thought Cody did an amazing job of putting that collection of people together. I don't know if she personally did it or not, but she certainly was in charge of the room, and that was refreshing. I will tell you, it was refreshing, not just for our agency, but for a number of agencies around. I've heard from other people. So kudos to you. So the state, I'm giving kudos to the state this year, right now anyway. And Jolene, your person was an awesome representative on behalf of Quest. So I just wanted to point that out publicly.
Thank you, David. Okay, hearing no more comment, we'll go ahead and close agenda item number 4 and move to agenda item number 5, which is the SAPTA update. I believe Tracy Palmer is going to go first, and Tracy and or Stephanie.
So good morning, everyone. I don't know if it'd be helpful if, let me start over. Tracy Palmer, Health Program Manager, for the record. And I don't know if it'd be helpful to have the agenda showing Jamie or Jolene, so that those who are watching, they can follow this agenda. So some of the things that I just want to bring forward for the substance use prevention, recovery, and the state opioid response teams. Those are the primary areas that I oversee as the health program manager here within the Bureau. I just wanted to bring forward some of the hot topics that's happening. I know that we have kind of a full agenda, so I won't go in major detail, but I definitely just wanted to let folks know that yes, we're doing that closeout of our general fund subawards. And then of course we are making sure that we are getting the amounts and numbers out of the general fund so that those who can get started on your fiscal year 24 subawards. So I know that we're getting close to the ending and also getting close to the beginning. So you should be working with your program staff. And if not, then if they haven't reached out to them, they should be reaching out to you. So hopefully that is happening. And then, as Tony had already mentioned, so I don't need to go there, about the strategic prevention framework announcement that had gone out to both supporting the state, but also supporting the community and tribal. And then in our in the treatment area, we are working on our request for application. And the as we had mentioned before, in other areas, the general fund subawards that folks have, it is not being affected by this request for application. And same thing for the anybody who had applied or been part of the Partnership for Success grant. The request for application has not been released yet. We will be announcing that. We have a big hope that by the end of April that it will be. We will definitely be announcing it across the board on our SAPTA listserv and making sure everyone is aware of it. Also on the call, and he's listening, I've been working behind the scenes of developing and putting together a recovery team. Because we all know that recovery hits all different key points of prevention and treatment, and then an ongoing sustainability. And so Brandon Beckman, he is the new health program manager within our Bureau. So we're excited to bring him on board. And this is a big encouragement keyword from SAMHSA about recovery and what our state's doing and supporting it. So we're just really happy to have him on board, and then at some point we'll be making sure that he becomes more known to all of you and speaking with all of you and getting some feedback as well. So and then the one thing that we just wanted to say, Recovery Advocacy Day, that's April 27th. And that is something, again, as we bring Brandon on board, he's already starting to hit the ground running and saying, hey, did you know Recovery Day is on April 27th? And so helping us in that recognizing those in recovery, helping them staying sustainable. And so he is just already making connections. And so we're really appreciative of that. Moving on to the state opioid response, just want to let you know one of the big hot topic areas there that we've been working with not only CASAT, but we're also working with OFI. The key is to meet that naloxone saturation plan that we have in place. And so we're working with multiple resources. Michelle Berry and I have been talking a lot and going through things. She may be hitting some of these areas, but that is something that we are working towards. And we're very close to meeting that. And I'm happy that we've been able to do a lot of collaboration between not only CASAP, but with OPI, and who has overseen the CDC grant. So they have an opportunity of a one-time purchase of naloxone, and so we'll be splitting that 50% north, 50% south. So that is on top of what we're already trying to do in a purchase through the State Opioid Response Grant. So more to come in the details of that. So with that being said, I will let Stephanie Cook, if she wants to add any more to what I've brought up today.
Stephanie Cook, I have nothing to add. Thank you.
Thank you, Stephanie. The last remaining item, sorry, Jamie. Tracy, again, for the record. And the last remaining item, to everyone's point, you had mentioned the stakeholder meeting. Yes, I was just going to say how, you know, on April 3rd, we had a stakeholder meeting. It's something that has happened probably one time in the last 3.5 years that I've been here. So I too was actually excited to have it. At the same time, yes, it's always hard to hear the hard feedback, right? We all have a hard time with that. At the same time, it was great to have it because it helps us see the gaps, and it helps us become more supported in our internal process. So those who attended, thank you. And those who didn't get a chance, we definitely still welcome the feedback. I know that you have Cody and Shannon's contacts. You also have mine. And so again, for those who did attend, though, I just want to say thank you. It helps us grow. And that's all I have. And we can go ahead and move on. Thank you.
Thank you. Is there any questions for Tracy before we move on to Jennifer? Okay, seeing none. Jennifer Tongle, do you want to tell us all about the Governors Association Deflection and Pre-Arrest Diversion Learning Collaborative?
Yes, good morning. Hi, my name is Jennifer Tongle. I am the Health Program Specialist with the SAPTA Treatment Law and Court Programs. Nevada's participation in the Learning Collaborative with the National Governors Association started in December with a request for application to the National Governors Association, also known as NGA. In December 2022, we wrote a proposal to the NGA for Nevada to participate in a learning collaborative on strategies to support the development of state-level deflection and pre-arrest diversion initiatives. We put together a core team of individuals in the state to build the proposal. Timing was difficult due to the new governor coming in right when the application was due. However, we were able to obtain Governor Joe Lombardo's support and traveled to Washington, D.C. with the Nevada team at the end of January 2023. Only 5 states were actually chosen and selected for the National Learning Collaborative for state-level deflection and pre-arrest diversion. The Nevada core team consists of team leader Lisa Sherrick, Allison Genko from the Governor's Office, Heather Benson from Lyon County Fast and Most team, Laura Yanez with NAMI Western Nevada, Christine Jones-Brady with the Attorney General's Office, and I, Jennifer Tongle, with the State of Nevada as a Health Program Specialist overlooking court and law treatment programs. The 5 states that were chosen were Pennsylvania, Illinois, Alabama, North Carolina, and Nevada. The kickoff meeting was essential in starting the 6 months of Learning Collaborative, where many similar strategies were shared for the very crucial pieces of deflection and diversion from our justice system. I wanted to personally thank all the support from Stephanie Cook, Tracy Palmer, Shannon Bennett, Cody Finney, Lisa Sherrick, and Dr. Stephanie Woodard in helping put the core team in place. It was insightful to know that we are all passionate about what we do as we help communities build deflection programs to help Nevadans where they are at. We appreciate all the support from our Nevada team as we were the only Western state chosen. I learned that harm reduction is a form of deflection, and we are already doing deflection in Nevada with our mobile outreach safety team, also known as MOST teams. Our summit was also a point of discussion as the Police Treatment and Community Collaborative, PTAC, were the main presenters at the kickoff meeting and facilitated these discussions. Deflection is the proper term that is used for early community sequential intercept model 0 and 1 in community involvement and is pre-arrest diversion that we see in the state now. In conclusion, to the kickoff meeting, there was a report back for action planning that included creating an inventory of agencies doing deflection to expand peer networks and seek funding streams, exploring measures to provide minimum data set for most outcomes, piloting the site for Lion Most to help identify leadership, engaging law enforcement with the Attorney General's office, and creating early intervention buy-in with NAMI Nevada Excellence in Deflection Award. Thank you.
Thank you so much, Jennifer. I appreciate that. Questions from members? Okay, seeing no questions, we appreciate that. Jennifer, was this a one-time report, or is this something that will be happening? Let us know after the 6-month collaborative is over what the next steps are. Is that a
Yes, we can
reasonable
definitely
request?
follow up. Yeah, not a problem. This is Jennifer for the record. Yeah, Jamie, I believe that we can definitely follow up with you and tell you how the progress has been.
Wonderful. We will plan on seeing you in one of the fall meetings then.
This is David at Bridge. If you don't mind, I'd like to ask a question. I'm trying to understand its value. It sounds interesting, and it's great that Nevada was chosen as one of 5 states, but I'm not quite sure. I was listening to the names and trying to figure out who I knew, and I'm just trying to figure out how that benefits the state. Other than, I just kind of curious.
This is Jennifer for the record. I just wanted to mention, in means of deflection, the state of Nevada is already doing deflection programs and meeting the patients at intercept 1 or 2 or 1 and 0. And so if anything, it's an upstream approach to making sure that we divert people from actually having to go into the justice system. And so if anything, that is the positivity part of it in means of the outcomes that we're trying to see is to reduce recidivism.
No, I appreciate that. And I think everybody on this board is aware that we do diversion or deflection, as they're calling it now. So just trying to figure out how we're somehow going to be part of that, or if we're just listening to what happened by a state entity. Thanks.
Thank you. And Elise Monroy, do you have a question?
I actually had a comment, Chair, if it's okay. So
according to Cody, it's fine. So yes.
So Elise Monroy, I'm here today with Bell's Case Government Affairs. We represent the Nevada Psychiatric Association as well as the as NAMI Nevada, but I actually jumped in because I am a former governor's staff.
Excuse
when I
me.
was with Governor.
Excuse me, Elise. I'm so sorry to interrupt you. I need to say that this particular comment needs to come during our public comment towards the end of the meeting. So if that's all right to hold that until that portion. Okay, thank you.
Why did you say that?
Yeah, I'm not sure why that would have to. The chair recognized her. I don't think.
Well,
we have to hold back.
So this is Stephanie. So during the agenda items, only board members are allowed to comment back and forth, and state staff. If there's public comment, that needs to wait until the public comment period.
Except that was important public input from what I understood. And when did that become the case? Because it never had been the case before. And where is it in writing? I'd like to see it.
Can I interrupt here? This is Cody. And I think we might be getting a little pedantic about the rule. So if Elise is not a board member and the chair recognized her, we actually could have an agenda that had public comment in every comment. The staff are trying to run an efficient and effective meeting. So if what you're making is public comment, there are specific sections for that. If the chair wishes to recognize someone to speak, she can do so. We can mark those as public comment. I will get with the staff and make sure we have clarity, but we're just trying to run an efficient and effective meeting and have things not get out of control or get sidetracked. So I'd appreciate if everybody could just try to recognize that we're all doing our best. Chair Ross, if you wish to hear Ms. Marsala's comment, forgive me if I'm pronouncing that wrong, Elise, at this point you can, or she can make it during public comment. It is a choice, but please let's keep the meeting moving forward.
Thank you, Cody. And I would, if it's okay, I would love to hear Elise. I know her experience from the governor's office is hugely valuable. And what she did for the opioid efforts in Nevada when she was at the governor's office are why we are all as far along as we are today. So Elise, would you be willing to continue to share?
Yes. So thank you, Jamie. So I was just going to say to David's question about like, what is the purpose of the Policy Academy? I'll just remind folks that the state's opioid policy work started with an NGA Policy Academy that I worked on, as well did many others on this call when I was in the governor's office. So what these policy academies can do is help the state at a leadership level take a concerted focus on addressing one specific issue. So Senate Bill 459, which expanded access to naloxone and the Good Samaritan Law, was a direct output of the NGA Policy Academy. So, to Dr. Tongol's point, yes, we are already doing diversion work, but being able to pull leaders together with technical assistance support from other states and the National Governors Association will really help Nevada distill their efforts and target policy and program work. I'm a big advocate and fan of NGA policy academies, and I'm really glad that the state and DPBH is continuing to participate in them. Thank you for the opportunity to add my experience with policy academies.
And if I might, I was also going to address Dave's, thank you, Elise. This is Cody. I was also going to address Dave's comment. So this is this Policy Academy. I've also participated in those related to other topics during my time at Medicaid. And the staff that are participating will get an enormous amount of education, staff and others, about how to implement policy moving forward. And then they will bring that back to the rest of us. I will say Lisa Sherrick has taken another position outside of the executive branch. So her role will be replaced. So I'm taking over as administrator on the 1st, and I expect that it's likely me that will be replacing her in that portion of the role.
Thank you. Those were very helpful comments. I appreciated them. I'm afraid if we had waited to the end of the thing, I may not be here, and that was helpful to do it in a timely manner. Thank you, Chair Ross.
Thank you, David. I don't see any other hands up.
I just want to clarify, it is David, never Dave, so thanks.
Thank you, David. Apologies. All right, that looks to be the end of agenda item number 5. We'll go ahead and close that one and open agenda item number 6, which is information on the CCBHC funding update from Lori Follett from Social Services and Joseph Turner and Mark Disselkoon from CASAT. So Lori, are you ready to present? It looks like your slides are up.
Good morning.
Hey, Jamie.
Thank you all for having us. And I think Mark is going to start us off and we're going to kind of tag team this for you.
Very good. Thank you, Lori. Mark Disselkoon, CASAT UNR for the record. Hello, beautiful people. It's great to see everybody, as always. So Lori and Joseph and I kind of worked on the slides, and that we can briefly go over a few things related to CCBHC, Certified Community Behavioral Health Centers. And I'm going to talk a little bit about, in brief, kind of what the services are related to CCBHCs and their oversight, and then Lori and Joseph can get into the funding map and so forth and so on. I did want to make a note. I've actually been involved with the CCBHC project going back to the 3 demonstration programs to 2016, and it's hard to believe that it's 2023. So Nevada has shown great leadership related to CCBHCs nationally, being one of the 8 demonstration states going back to 2016. You can turn the slide or flip the slide. So I just want to go over just the basic services that the CCBHCs provide. And I just want to give a lot of kudos to the CCBHCs. They've done a lot of hard work. This has been a heavy lift going from maybe traditional substance use treatment programs with some mental health to going to a whole other level, providing an array of services. And also just dealing with workforce issues and being able to hire appropriate staff is always challenging. So they've done a great job. They work very hard and they serve a lot of people in Nevada. So I just wanted to give them some love. So just the core services, just so everybody knows. So the first one is mobile crisis services. That's 24/7, 365 a year. Mobile and on-site. Sometimes crisis services gets a little confusing because it's not just mobile, it's also many crisis services come to the CCBHCs. Some of the CCBHCs go to local jails and do crisis services there, so forth and so on. They are obviously required to do screening, assessment, and diagnosis. And probably the biggest difference between like a traditional SAPTA certified SUD program and a CCBHC is there are specific screening requirements that they have to do, and certain evidence-based tools that they need to utilize related to screening, as well as the assessment process. And they're not just doing services for individuals with a substance use diagnosis, but also a co-occurring diagnosis, as well as mental health only. They also have to provide services to children, adolescents, and adults. So it's much more robust. It's not a choice. They have to provide these services to these different populations. They need to provide person-centered and family-centered treatment planning. And again, that is very specific to what the client's needs are. And treatment plans need to be outcome-driven, behaviorally driven, showing symptom improvement, so forth and so on. Outpatient mental health and substance use services. This includes medication management for children, adolescents, and adults. CCBHCs do not provide residential services, though some of our CCBHCs do have residential services, but that's a separate unit from the CCBHCs. So from the SAMHSA model, it is outpatient only, which is 2.1 and level 1 and 2.1, if you were kind of thinking of it from an ASAM model. They have to provide outpatient clinic primary care screening and monitoring. So there are a number of health indicators that SAMHSA requires the CCBHCs to report to the state, and then the state reports those to SAMHSA. Right now, there's 21 outcome indicators. There's going to be actually less with the updated CCBHC standards that SAMHSA recently approved. This is a big deal because it helps them to identify any kind of healthcare types of issues and to be able to either provide the services themselves or refer them to primary care for additional services. One of the beautiful things the CCBHCs often do, though, is they provide primary care within their model. It's not a requirement that they provide primary care within their model for a CCBHC, but they can get reimbursed for that through Medicaid. So often, because they have individuals, they either have a doctor or a psych APRN or a PA, they can actually do some primary care. So the more services under one roof, the better, which is always the encouraged kind of method. Targeted case management services, it's kind of similar to general case management or the Medicaid, but it's targeted to certain populations. And so this, again, is not an option. They have to provide case management services. Psychiatric rehabilitation services, PSR, basic skills training, for example, as well, have to be provided by the CCBHCs. And again, this really has expanded a traditional SUD program to be able to do much more than they would traditionally do under just a SAPTA certified SUD COD program. CCBHCs have to do peer support, peer counseling, and family caregiving supports. So our CCBHCs need to either hire or contract with peer support specialists for both SUD, COD, and mental health. And again, this is a really important level of service because peers can begin to work with individuals while they're in treatment, help them to get connected to the community prior to discharge. And so it's really refreshing and nice that the CCBHCs are providing the peer support services and helping clients where they're at. The next one, which is number 9, is intensive community-based mental health care for members of the armed services and veterans. Again, this is very important to SAMHSA and is a required level of service. Often, there are people in the military that or have been in the military that work for the agencies who are credentialed and provide really good services. We also provide a number of trainings that we coordinated with the VA that treatment providers, CCBHCs, can actually take those trainings and gain some expertise related to treating veterans. And then the last one is assertive community treatment teams, ACT. And again, this is kind of a heavy lift when you're doing a lot of other things, but a lot of the CCBHCs have really taken the ACT model to heart and are doing a really, really good job. And so the ACT teams are separate than the mobile crisis teams, and they often do services within the individual's home. And really the goal is to help that person live in the community, stay out of the hospital, and just give them that extra support that often some clients need. Okay, so that's just the core services. Just one more slide for me, and it's the next one. Just some of the other things that we look at related to certifying CCBHCs. We look at staffing plans, so they're in compliance with Medicaid policies and various boards of examiners. We also make sure they have the number of staff needed to be able to provide the 10 services that I just talked about. They're required to have care coordination agreements with criminal justice, juvenile justice, the schools, Indian Health Services, tribes, et cetera, et cetera. There's a number of care coordinations that they work towards having. We require them to work towards it. Sometimes people aren't willing to engage and have a care coordination agreement, but our providers have done a really good job. I just want to give kudos to Lana at New Frontier. She has not given up on the schools. She kept working on the schools in Churchill County. They didn't want to play, but finally they made that threshold, and now they're in the schools and really providing good services and coordination. So sometimes it's just that steadfastness, sticking with it, not giving up, so forth and so on. So I just wanted to share that. We require our CCBHCs to do ongoing needs assessments. So they need to look at community data. They need to show that they're utilizing that data to make informed decisions about care and what is needed in their community. CCBHCs are required to have a robust continuous quality improvement plan. So when we go in, we look at that. We want to see that they have a CQI plan, but they are also implementing it and documenting how they're utilizing that. We look at board governance as well as training plans, because there's a number of trainings that CCBHCs are required to have. Most of those trainings are free of charge via the CASAT Learning Training site. I've done probably 80% of them, all related to CCBHC kinds of requirements and so forth and so on. And before I turn it over to Lori and Joseph, I just wanted to remind people what the core team is. So there's the CCBHC core team, which is basically made up of Medicaid, healthcare quality compliance, CASAT, and then there's other people within the division that are involved in that as well. And so Lori is our fearless leader on the Medicaid side, and she's wonderful to work with along with Joseph. And so I'm going to turn it over to Lori for the rest of the presentation. Thank you, everybody.
Perfect. Thank you, Mark. We can move to the next slide, please. This just goes through and explains to you who our CCBHCs are currently, and these are under the Medicaid plan. And you might say that I say there's 8 there, but you're not seeing that many dots on the screen. And a lot of these providers are actually represented on this board, but Bridge Counseling has 2 locations, Carson City Community Counseling, New Frontier, Quest Counseling, Rural Nevada Counseling, and then Vitality also has 2 locations. So we have a number of them spread out across the state. We can move to the next slide, please. We have here, this has changed actually even since I prepared this slideshow for Stacy to post. We have 2 SAMHSA direct funded CCBHCs, which is Vitality Unlimited in Reno and Dayton. Silver State has stepped away from that SAMHSA program. We also have Carson City Community Counseling, who did get a grant from SAMHSA as well. A little bit different of a capacity than how they've been handled in the past. We do have requests for additional authority, additional budget authority for CCBHCs under the Medicaid state plan, and that is currently under review with our current legislative session. We do hope that our budget will be heard again. I believe it'll be in May. So if anyone is interested in hearing about that, you can reach out. I can let you know when it will be heard. I don't have a date on it just yet. So if that is approved, we will go through an official procurement process, and that will allow us to add 6 under legislation, and then we have 1 current empty position. So we will be adding hopefully a total of 7 after this legislative session, and they all fall under the Medicaid provider type 17188. Next slide, please. We do a variety of data collection, and I do have Joseph on the line, and he does a whole lot more with regard to all of the billing and quality, what and whatnot. I don't know if Joseph, you have anything you want to jump in and add to this slide or expand upon.
Yeah, I'll talk about the billing just a little bit. The billing of services tracked by Medicaid, we offer this underneath fee-for-service and managed care organizations. It was previously carved out prior to January 1 of 2022. And we have had some issues with some of the MCO implementation, but I believe that we're actively working and have resolved most of those issues. And providers bill a T1040 code in the header level of the claim, and then they provide in the detailed billing level of the claims, shadow billed claims. That gives us insight into what services were actually being delivered underneath that T1040 code, along with the number of units. This is helpful for us in evaluating, what services are actually being provided at the CCBHC, how much time is being dedicated to delivering those services, and then those also drive some of the quality measures, which we use in order to collect, or which we collect from the providers in order to drive quality incentive payments, which can be up to 15% of the PPS rate that we set. That's prospective payment system. All CCBHCs are set a provider-specific rate based upon cost reports that are completed and submitted to us. And then the 21 quality measures, there's actually been recent CMS guidance, which is changing some of the metrics for those measures, but we're still waiting on the details and the technical specs to come out from CMS in order to provide guidance on what is changing those. Additionally, with the quality measures, we meet bi-weekly with all CCBHC providers in order to provide technical assistance and in both collecting the measures and then generating extracts, which are used for the quality measure calculation.
Thanks, Joseph. Yes, the quality measure calculation, otherwise referred to as our quality incentive payment system, incentivizes the CCBHCs along the way. We already know they do good work, but this is our way to reward them for that good work. All CCBHCs also submit training activity logs to us, hopefully monthly, and we keep track of those and review all those trainings when we visit them on site. Mark touched a little bit on that, but we do have a pretty high touch with our CCBHCs. We see them on site usually a minimum of once a year. So we have a really good relationship, really good rapport. So we appreciate them all. You can move to the next slide, please. Does anyone have any questions for us? Is there anything we can do to expand upon what we've talked about or make anything more clear about the CCBHC role in your community? We are here to take questions.
I do want to add something. Just the core team meets every other week, and that's a very productive time where we're able to discuss kind of how the CCBHCs are doing. Also, it's an opportunity when CCBHCs have questions about a number of issues, we can bring them to the core team and discuss through that, and then we can get a uniform answer back to all of the CCBHCs, which is helpful. Even SIRS sits on the core team as well as part of Medicaid, and that's very effective. Many of our CCBHCs periodically do go on corrective action plans, and that's very helpful to just help them to just, move forward. We provide technical assistance to help them with those. So, sometimes there may be concerns in the community. Rest assured, we know what the concerns are. We're out there, we're helping them, and they're great at working on always continuously improving in the services that they're providing. And Jolene has a question.
Thank you so much. Jolene.
Thank you, Madam Chair. It's more of a comment. I just wanted to thank Joseph, Mark, and Lori for the presentations. I think although we are a CCBHC at Quest, there's still a lot of people out there who do not know what a CCBHC is, and I'm always surprised by that. But that's because we, live in this world every day, and they don't. So I think the presentations were very helpful for other people on the board who are not a CCBHC or, other people joining this meeting, because I think, every year there's more and more opportunity to become one. So thank you very much for those.
Thank you, Jolene.
Hi, this is Esther Quillisi. Could we get a copy of those slides?
I think they posted them, if I'm not mistaken. They should be posted.
Yes, this is Stacy Whitkey, and yes, they're on the SAPTA website. If you follow that link that I sent, Esther, you will be able to get right to it.
Okay, thank you.
This is Jamie. I have a couple of questions, and I'm not quite sure who will answer them. First question is, for a while we had some what I heard people call baby CCBHCs, and I'm curious in that it feels like it was a year ago, which means it was probably pre-pandemic because that's how time works. So how many of those made it to be big kid CCBHCs, to use, again, terms I'm just making up?
So Jamie, this is Lori Follett for the record. We haven't added any big kid CCBHCs or fully funded Medicaid CCBHCs since I believe 2019-ish. So nothing recently and nothing in the last 2 years. So all that we've been working with currently in the communities are the SAMHSA funded CCBHC, and those are grant funded. They are not reimbursable by Medicaid. Those facilities, we've been working with them. If they're interested in working with Medicaid, we'll enroll them in other provider types, but we haven't added any new ones. So we currently have the list that we showed in the slide, and that's who we have funded under Medicaid currently.
And Jamie, so the 8 PT 17188s, those are full service, CCBHCs. And, some of them are on POCs, and we're addressing any, service concerns, related to them, just so you're aware of that.
Thank you. And then second question, I'm here at the Atlanta Prescription Drug and Illicit, the RX Summit. And I heard someone from SAMHSA say that the CCBHC rules are changing. And that seemed to have kind of rolled out very recently. Can you guys talk about what those CCBHC rules will be adding, changing, subtracting. Seemed like more medication assisted treatment was the key piece that I heard. But again, I work in prevention, not treatment, so
Right.
I'm just being dangerous.
So Jamie, this is Lori. The SAMHSA did just roll out new criteria. That criteria does not take effect until July of 2024. And then the actual rollout date has to do with some other complicated things. So it'll be at least a year in the future. Our current core team that Mark described to you, we will start meeting in June to go over those changes. Mark or Joseph might be able to speak to a little higher level summary of what we expect those changes to look like. But we at the state really haven't really dug into them too deep yet. So Mark or Joseph, do you want to add?
Yeah, high level overview, and Mark can fill in any gaps that I miss here. There are going to be changes to some of the crisis requirements. I believe they're going to enhance some of those. They're also talking, you had mentioned Matt. There is some guidance coming on that. Everything that we've received from CMS so far has been more summary level. We haven't really gotten any of the detailed criteria. I think that a lot of it is going to be addressed. I had mentioned that we're waiting for the technical measures to be released around some of those quality measures, and some of those quality measures tie to the new required, the newer enhanced requirements around some of the services. And they're also backing off on some of the other areas of requirement. I think that we're related to some substance use treatment areas. And then finally, the quality incentive payment methodology, they are changing it. We currently have a state plan amendment pending to change the quality incentive payment calculation. As many of the familiar faces on this call will explain to you, is that the current methodology, if you, for the 6 required measures that feed into the quality incentive payment, if you hit the minimum denominator for any of those and then miss the threshold, then that whole 8.5% chunk goes away. And what we've changed in the state plan methodology is to create those all standalone, so that there's incentive to work on each measure individually.
Yeah, that's really important related to that. I do want to say that they asked current states that were doing CCBHCs to complete a survey and give them feedback. So the core team did do that and made a number of recommendations, really having to do with efficiency of some of the requirements. Because as you know, sometimes SAMHSA could overdo it with, the level of regulation. And so some of that stuff was definitely taken into consideration. Just one example is I talked earlier about care coordination agreements and getting people to play with you in the sandbox and, do formal care coordination agreements, and they're not always helpful. There is going to be some loosening of like the care coordination agreement kinds of things, as well as supporting programs like ACT. There's going to be some level of that in there as well. So, but we'll have more on that. We can come back at a later SAB and, discuss, once we've got to meet together as the core team to go through it, we'll give you a better answer.
Yeah, and then one other change that I do know that is going on in the legislature right now is there is a legislation currently proposed for another 5%. So this would be on top of the 15% quality incentive payment, but another 5% of bonus payment for contracting with a education agency. So if you have a contract with an education agency that falls within your catchment area, such as the one Atlanta just got in place, they would qualify for a 5% bonus on top of that PPS payment. And then one other thing that is really important about CCBHCs is that there is no prior authorization required for any of the services delivered. They have a no wrong door approach, and anybody can come in regardless of their ability to pay, and providers will serve them. And really appreciate all of the work that all of the CCBHCs do. It's indicated through some of the little kid to big kid transition that many of the providers were just not able to handle that lift of becoming a CCBHC because it's very, very intensive.
Thank you. Lana, could you, sorry, David, go ahead.
Thank you. Yeah, so we've heard a lot from the state representatives on CCBHC, and I just wanted to just give you some input. One, the core CCBH core team, there is no representation from CCBHCs in that core team. They take back only what they remember from our meetings, so we're not represented in real time at those meetings. So there is that, and then there's also it is a bit of a heavy lift. We're excited about what the new rules will be, but I would strongly recommend that if you're interested in becoming a CCBHC and have that opportunity to apply to become a CCBHC within the state, I think CCBHCs are tremendous. They're the best thing that's ever happened in Nevada, quite frankly. And it's, in fact, I think it's probably the best thing that's happened to behavioral health because it does provide an integrated approach. However, you need to know the rest of the story, and I would recommend that you contact a leader from one of the CCBHCs in Nevada just before you go to all the work of doing it and then realize, oh, you don't want to do that necessarily. And it looks great in black and white, but it is a challenge, and we have no intention of abandoning it. But it does require give and take, and I think that we need a better working relationship directly with the state CCBHC core team that does not necessarily occur in our meetings. So just making that public, since we have representation here of people of interest, and since there is an opportunity for other agencies to become CCBHCs, and I strongly encourage it. And if you can do that, then absolutely do that, because it is a terrific opportunity. So that was kind of a plus and a minus. So, but all along, it's CCBHCs is better than not. Thanks.
Thank you, David. Lana, to follow up with what Joseph had mentioned, can you talk about your education component?
Well, I'm sure I'm no different than any other provider out there. We've tried for years to get involved in the school. We're strong partners with our community coalition that has always made a strong effort to get into the schools on the prevention side to be able to my belief is that we need to get the kids before there's issues, before they're adjudicated, instead of after, when we have them as a captive audience. So that's always been something that we've been marching toward. We've been very lucky at being offered rooms in the high school to provide treatment, so that the students don't have to leave school, have their parent bring them over to the treatment center, lose all of that time. This way they just come out of class, meet with their counselor, and then go back to their classes. So it was a win-win for everybody. And honestly, we're hoping that between the coalition and New Frontier, we're going to make a really strong presence in all of our schools. So that's where we are right now. We also do bring some prevention programs in under a grant that we had received through some of the extra funds that we had the ability to apply for in Nevada. And with those, we're bringing programs like vaping, well, not to vape, I guess, not teaching them how to, but, sorry. But not to vape. We're bringing some other programs in different classes. So it's a combination of all of the above.
Thank you. That's really helpful. And Mark?
Just to follow up, I do hear David, and I appreciate his feedback. There is a bi-monthly NAP meeting where the providers and the core team does get together and tries to go over different things. We also schedule regular meetings with CCBHCs if they have specific concerns. or technical assistance needs, which is helpful. The core team, obviously, the reason why the CCBHCs aren't involved in it is because we're talking about corrective action plans of other CCBHCs and Medicaid billing types of things. So it'd be inappropriate for CCBHCs to be a part of the core meeting, but that doesn't mean that we don't try to meet with them on a regular basis. I just wanted to note that.
But there's ways of keeping those as exceptions from a meeting. So just a thought. We don't always have to be in on everything, but I think it would be helpful if we had real-time involvement. So I don't want to just leave it there. Thanks, Mark. I appreciate what you did and said, but I don't want to just leave it there.
Okay, that's good. Thank you.
Other questions, comments? Okay, wonderful. Thank you so much to Lori, Joseph, and Mark, as always, for your great presentation. We'll go ahead and close agenda item number 6 and open agenda item number 7. And Ms. Michelle Berry will be talking about the State Opioid Response, Subawardee, and CASAT budget breakdown.
Sure. Thanks, Madam Chair. And my name is Michelle Berry. I'm a Senior Project Manager with the Center for the Application of Substance Abuse Technologies in the School of Public Health at the University of Nevada, Reno. I have several of my colleagues with me, Morgan Green, Karina Rivera, and Michelle Padden, and you just heard from Mark Disselkoon. To be in compliance with the agenda, I think I put too much in this presentation. Can we start the presentation on slide 27, please?
Hi, Michelle. This is Stacy Widke. Sure, I will get that going here. If you'd help me identify that, the way I have this set up, I don't see pages.
Michelle, could you get closer to your mic? All I get here is reverberation.
I don't know how to get closer. That's a good question.
Okay, then just lay it off to my advancing age. Never mind.
Keep going. It'll say sore.
Am I close, Michelle?
Keep going. Keep going. Keep going. Keep going. Okay, perfect. Thanks. And then the next slide. Thank you.
Okay.
All right, so I'll be discussing the State Opioid Response Grant and the activities that we've done and provide a budget breakdown for the SAPTA Advisory Board. So CASAT's role for the State Opioid Response Grant is listed here. We help and partner with SAPTA to deliver the dollars into the community. We also help to issue NOFOs and review applications, execute subawards, and then work through the RFR process. We facilitate meetings with our subawardees, collect all of the reporting information that is required for submission to the federal funder, and then also distribute naloxone fentanyl test strips and administer our Adopt Expert project and help with the organization of media campaigns. Next slide. So this is the timeline of what the state has received for SOAR. So it started with the State Targeted Response Grant in 2017 and then moves forward into the State Opioid Response Grant Part 3. As you can see, in multiple years, we're working under dual funding. So we're receiving a potential no-cost extension plus year 1 of the next iteration of the project. And so this has been what we have been looking at since starting this project. Next slide. This is the amount of pass-through dollars that CASAT has received to distribute within the communities for each iteration of the project. The total overall amount that the state has received for the State Targeted Response Grant is $11.2 million for 2 years for STR, $14.2 million for SOR 1, $21.8 million for SOR 2, and for SOR 3, the state is in receipt of $33.4 million. Again, the numbers I've just described are the numbers for 2 years worth of funding. And the numbers that you see here are what CASAT has been issued to subcontract into the communities. The what is described here are the main parts of the project that we're focusing on for the subsequent iterations of the project. Next slide. So our main state opioid response target areas consistently remain the same. These were also born out of several of the opioid meetings that we had at the beginning of the term in 2017 and have consistently been updated with updates that are happening across the state. But the main priority areas remain the same. Next slide. Since the beginning of the State Targeted Response Grant, these are the organizations that have received any type of subaward funding. The ones with the stars are organizations that no longer receive funding because their project has either naturally ended, or they have met all of the deliverables in their scope of work, or they have become sustainable in some manner. But as you can see, there have been quite a few subawards that have been executed. Next slide. So funding by category, the majority of SOAR funding goes out into direct substance use disorder treatment services at 80%. Recovery support, 11%, early intervention, 4%, harm reduction, 2%, training of our providers. And this is training of primary care providers throughout the entire spectrum of providers, and then towards media campaigns. And then to the right, the expenditures that we've incurred. Next slide. And then funding by direct service type. As you can see, our opioid treatment programs are the ones that the majority of the dollars go to. And I think that that's primarily because in the first iteration of SOAR, we were looking at opioid use disorder treatment only. And then in SOAR 2, it opened it up to stimulant use disorder plus opioid use disorder, and then opened up more direct service types. So this is the funding breakdown per service type. And we comply with the same dollars that SAPTA provides to providers. So SOAR doesn't have its own fee structure. It complies with the fee structure outlined by SAPTA. Next slide. And our direct service breakdown. So the number of treatment episodes that we provided through our subawards to direct providers, the median length of stay in treatment, the days, and then the average cost per client, which is significantly lower than what the national average is. Next slide. So part of our role under SOAR is to serve as the state's distribution site for naloxone. These are updated figures for what has been distributed throughout the state between February 2018 and March 2023. Next slide. We also work collaboratively with the Southern Nevada Health District for the distribution of fentanyl test strips. And this provides an overview of the number of fentanyl test strips that have been distributed, the distribution priority for how test strips get distributed, and the number of distribution sites we have. Anything else to add?
No, this is relatively new just because we really weren't allowed to go this route up until it was given to us by both SAMHSA as well as Nevada legislation. So really, this really is about a year's worth of distribution efforts. And so I just want to kind of congratulate, because so many of you are a big part of this distribution piece and really promoting that harm reduction approach that has been shown to be so effective in this area.
Next slide. Under SOAR, we've initiated a neonatal abstinence syndrome prevention project in collaboration with the ASTO Omni Group. We've developed both an inpatient and outpatient reference guide for labor and delivery, especially when there is a pregnant individual with an opioid use disorder. So we have been working with this distribution and for training primary care OBGYNs on the best practices for care. Next slide. And then we have been working collaboratively with Track B to promote a emergency room peer-based program. So this started at Renown in June of 2021 and then at UMC in April of 2022. And then the following numbers describe between both hospitals how many handoffs were provided, screenings completed, and then individuals referred to care and brought to care. And so overall, the program has been successful. We've received inquiry if this will continue. And for now, the program seems to be working, and we're looking at potentially growing this to other hospitals. Next slide. Under SOAR 2, we also funded the Zero Suicide Initiative. This was in collaboration with the Office of Suicide Prevention, and it was really targeted towards hospitals to promote a more seamless referral to care. And so at the time that this presentation was developed, we had completed 2 rounds of a learning series looking into 21 healthcare systems and providing ongoing communities of learning and communities of practice for the hospital systems that were participating in the initiative. Next slide. So as I mentioned previously, we have been involved in several media campaigns targeting specifically anti-stigma, naloxone awareness, how to seek treatment for both the individual and the family member concerned for the individual, and promoting a recovery-friendly workplace. Next slide. And then some of the campaigns that were developed were also recipients of awards. The I Never Thought campaign won the American Advertising Federation's Best in the West competition. And then in 2023, our Faces of Recovery campaign won in several different categories. So that concludes the presentation. I'm happy to take questions.
Thank you so much, Michelle. Questions for Michelle? Michelle, I heard something on one of your slides. You it said that the current award was 13 million, but I swear in my head I heard 33 million.
13
I may be the
million
only
is CASAT's allocation for distribution into the community. 33.4 million is the state's overall amount that they would be receiving, but that's over 2 years.
Got it. So so you'll get 13 million a year, totaling 26-ish, assuming that you guys keep the.
Assuming this moves forward, but the 13 million goes directly out into the community.
Okay. Thank you. No questions?
But I do have to say, you know, in conclusion, like the subawardees that do participate in this project are really tasked with a lot. They have to collect a lot of evaluation specific data. The GIPRAs are a labor of love. But Nevada's GIPRA rate continues to be recognized nationally for how Nevada is performing overall with getting those GIPRAs in, being on time with how those submissions are going. And so that's a testament to how our subawardees are performing. And then I recognize too that it's been difficult because our award has been delayed, thus making our subawards delayed. And so their patience has been, I've appreciated how patient they have been. So this really goes out to our subawardees.
So Michelle, this is Esther. What is a GPRA, a GIPRA?
or GPRA, the Government Performance Reporting Act. So it's a series of questions that are required by SAMHSA that each individual client receiving service, engaged in service, has to complete. And so we're mandated by the project to maintain an 80% rate of return to the funder.
Is that what you report to SPARS?
Mm-hmm. Yeah.
Uh-huh. Yes, we do. We know SPARS, and you know what? It is a wealth of information that all CCBHCs or all of us should have started reporting, because I think it would give us a great foundation to show how effective we are. Because I know that when we report to SPARS and we can capture some of that information, it is amazing to present to locales to show how effective the clinics are or how effective our services are. It is not an easy thing, but it is very beneficial.
So we provided GPRA reports summarizing all of the information that we've received from our subawardees back to the subawardees. So it's individualized agency level reporting.
Thank you so much, Michelle. I know that you and I spoke about this what feels like a year ago, having you present this information. So I'm glad we got all of this out. And I know the same comments that we all had in our public meeting of it takes a really long time for us to all get funded, I think seemed to also be an issue with SOAR. Because unfortunately that is just the nature of the beast right now. So I just want to say thank you for everything you guys are doing.
Okay, I have another question, Madam Chair, and I've asked this to Michelle. Hello, Michelle. SOAR 3, is there a rollout for the request for proposal?
Sure. A NOFO has been developed for SOAR 3, which is currently under review by SAPTA. Once SAPTA gives the green light, we will be releasing the NOFO.
Okay.
Thanks, Esther.
Thank you.
This is Leo Magardich, and I have a question. Are there any specific changes to SOAR 3?
Yes. So SOAR 3 still is looking at opioid use disorder, stimulant use disorder, but really is focusing on recovery support services and prevention services. So primary prevention services is something that has been integrated into SOAR 3 that has never been there before. Previously, it was secondary or tertiary prevention, but primary prevention is something that it's highlighting, which we were excited about.
Thank you. I have no further questions.
Thanks, Leo.
Any other questions? Wonderful. I look forward to reviewing the first 27 pages of your slides at my leisure. So thank you so much to both of you for the presentation.
Thanks.
All right, we will go ahead and close agenda item number 7 and open agenda item number 8, topics for the next meeting. And Esther, I will go ahead and request that we get a copy of the bylaws and all of the members of the board. And by members, I mean member agencies of the board.
Thank you.
Thank you, Esther. Topics for next meeting. Okay, hearing none, Jolene and I will work with state staff to come up with an agenda for the June meeting. As always, these are the, I believe, second Wednesday of every other month. And let me go ahead and close agenda item number 8 and open agenda item number 9, public comment. This is the last public comment. Okay, I'm not seeing any. I will go ahead and close agenda item number 9 and then move to adjourn the meeting at 10:32 a.m. And we will see you all on June 14th at 9 a.m. Thank you all so much and have a lovely day.
Thank you. Bye.
Thanks,
Bye,
Jamie and
all.
Jolene. Good job today.
Thank you.
Thank
Bye,
you.
guys.